talking about, thank you, Kelly, who's going to be here talking about therapy options, particularly for those in our care who are diagnosed or suspected of having an FASD. So Jessica, welcome.
Thank you so much, Stacia, for having me this evening. I'm so excited to be here and talk with all of you about some therapy options for these kiddos that need it so much. So again, my name is Jessica Wilson. I'm a licensed clinical social worker. I work in both the states of Virginia and Florida, located physically in Florida. And I have been doing this for about 5 years, actually. So I have quite a lot of experience working with families who have kids that are prenatally exposed to alcohol. I'm also adoption competence trained. So I have worked with a lot of kids and families and caregivers in the adoption world. So as a lot of you know, those things intersect a lot. So I was trained postgraduate at the Florida Center for Early Childhood here in Sarasota, Florida, and they have a fetal alcohol spectrum disorders clinic there where they do diagnostics and treatment of FASDs. So that's where my primary training is. I'm now working in private practice, so I provide care to kids who are prenatally exposed to alcohol and drugs, as well as other neurobehavioral disorders, which we're going to talk a little bit about tonight, and their caregivers and families as well. I also work with teens and young adults who have brain-based challenges, so kind of all over the map with that. I have 3 neurodiverse kids myself, and I have ADHD, so I have a whole household full of people, as many of you do, who have some of these challenges. My stepdaughter actually has prenatal alcohol exposure. She's 16, so I've walked this journey as a parent as well. So what we're going to do is I'm going to spend about 40 minutes or so just talking through some of these therapy options, and then we'll have some questions after, and you guys will have the opportunity to pop your questions in the chat so I can answer those at the end of the session. So I'm just going to share my screen and we'll get started. Hopefully that's popping up there. It's giving me a little bit of a delay, but all right. So we're going to talk a little bit first about what exactly do we mean by FASD and neurobehavioral conditions. Some of you may be familiar with what that means. Maybe for some of you, this is a newer concept. So what is a neurobehavioral disorder? These are conditions that involve impairments in cognitive areas of the brain that can affect emotional well-being and also cause behavioral challenges as well. This is based out of neurological differences or brain dysfunctions. And so the difference between a neurobehavioral disorder and a behavioral disorder, it lies in what's going on in the brain. So some examples of neurobehavioral disorders that commonly affect children are things that everybody who's heard of autism spectrum disorder. ADHD is another one. All the FASDs, fetal alcohol spectrum disorders as well. There's other learning disorders that are considered brain-based challenges as well, intellectual disabilities, even post-traumatic stress disorder. So kids who've been through a lot of trauma can also have brain changes that manifest in this way. And a couple other examples would be Tourette syndrome, a traumatic brain injury. So if a kiddo gets, a head injury or something at a young age, that can impact that as well. And then epilepsy. So this is not an exhaustive list, but these are some of the most common disorders that affect kids from a neurological perspective. So understanding specifically FASD, which is really going to be what I'm primarily focusing on tonight, but I wanted to also kind of list some of those other things because they fall into this category as well. Not all kids who are struggling with these symptoms have an FASD. So when I talk about neurobehavioral disorders, FASD is kind of the biggest one, but I don't like to forget about all the others as well. But FASD refers to a range of effects that we see in kids who are prenatally exposed to alcohol in the womb and the brain changes that come along with that. So that can include physical health conditions, medical issues, as well as behavioral challenges, mental health challenges, learning disabilities, and difficulties. And early intervention is really what we want to see more of. And so, the earlier that we can get a diagnosis and start treatment, the better the outcomes are going to be for these kiddos. And that doesn't mean that if they get diagnosed when they're older, that we can't still have some interventions that are really useful. It's just that it changes. And we're going to talk a little bit about that when we get to the slides on interventions of what ages that each therapy approach is more suitable for. So some challenges in a little more detail that these kiddos can be faced with are cognitive impairments. So things like, memory, having a lot of trouble with that. A lot of kids really struggle with working memory. Their attention span, so being highly distractible, fidgety, difficulty focusing, and problem solving challenges. So just being able to understand abstract concepts and being able to work through problems from a day-to-day basis can be really challenging, something that most of us take for granted. Behavioral issues, also very prevalent in this population. Not always. I've had quite a few kiddos I've worked with where this isn't present, and every kiddo is different, but you're going to see higher levels of impulsivity and hyperactivity, sometimes aggression, things like that. Social difficulties is another big one. So being able to understand social cues, knowing how to act in social interactions, making and keeping friends can be really hard. And then we also see a lot of academic challenges. So there's, learning disabilities are really prevalent as well. But academic challenges can also come from some of these other symptoms. So if a kiddo is struggling with memory and attention span, they're gonna, have a harder time in school. So we do a lot of work also just collaborating with schools, and we're going to talk about that as well. So a multidisciplinary approach is what is really first line treatment for kids who have neurobehavioral disorders. And what I mean by that is not just one provider working with a kiddo, right? We want to have collaboration with a team. So that can include, a child's physician or other healthcare providers, their teachers and educators that's in their school environment, and a variety of different therapists, which on the next slide we're going to talk about. Ensures a really comprehensive plan of treatment that will really look at, physical medical needs, educational needs, academic needs, and psychological mental health needs as well. And the earlier and more individualized that these interventions are, the better the outcomes we see from a research perspective, particularly with mental health, which is what we're going to be focusing on for the majority of this presentation. But I wanted to give a little bit of background to just for anybody who might be newer to these concepts. And so ongoing support, a lot of these kids are going to need support for a long time. It's not just, okay, 6 months and we're going to treat all these things and we're done. These kids are going to need supports and accommodations for the duration of their childhood, really. And so possibly even into, adolescence and adulthood. So we want to know, a lot more about how do we adapt life for them so that they can be successful. So what does the multidisciplinary holistic approach look like? For a lot of kids, there's going to be pharmacological interventions, which is essentially managing medication. So this would be working with a physician or psychiatrist to discuss medication options if needed. There are some families that choose not to use medication, and that's perfectly fine too, but that's an option that a lot of families need and want. So that person should be on a team with all of these other individuals as well. A lot of kids that struggle with social deficits and speech and language delays work with a speech language pathologist to help them get therapies for those issues. And then also occupational therapy. So a lot of these kids have struggles with sensory processing, self-regulation and behavior, and a number of other things that an OT can really help with and be part of that multidisciplinary team. Educational support is really, really crucial as kids start school. Getting an IEP or 504 plan in place that outlines the accommodations that that child needs in collaboration with parents, caregivers, and the rest of the team. I certainly, even as a therapist, attend lots of educational meetings with my families to support and advocate for the kiddos that I work with. So this is a really critical piece for educational success. Family and caregiver involvement is also something that I highly recommend. Sometimes therapists want to work with kids one-on-one and just they really value that confidentiality and the therapeutic relationship of one-on-one care, which is, that's fine. Some clinicians, that's how they work. It just, from a research perspective, outcomes are so much better when we involve caregivers and families really heavily in the treatment process. So we're going to talk a little bit more about that. And then mental health treatment. So that's where I come in as a mental health professional. So working on some of the emotional and behavioral challenges, supporting parents, and also trauma. Sometimes there's a lot of trauma that needs to be dealt with, and how we treat trauma in kids with prenatal alcohol exposure looks different. So we'll talk about that too. So prenatal alcohol exposure puts children at a higher risk of having mental health challenges that are unique. And so we want to be aware of that when we're looking for treatment, that this is not going to be, run-of-the-mill mental health treatment. Their brain challenges put them at risk for things that are a little bit different. And so the most effective interventions are usually individualized to that child's needs and strengths. So using positive reinforcement encourages, the behaviors that we want to see over punitive methods of behavior. Usually works a lot better. So positive behavior support and positive reinforcement using the child's strengths. So identifying strengths is something that I do a lot of in practice to try to figure out, how are we going to work with this child in a way that celebrates their abilities and not their disabilities. Structured routines are something that I also really emphasize in mental health work because it really promotes stability. So if we have kids who've come from hard places, that stability and routine can be really beneficial for them, but also their brains function more optimally when they can have a predictable routine, both in therapy and at home and at school and all the places that they spend time. Teaching strategies to both parents and children for managing symptoms such as impulsivity or a lack of self-regulation, those big behaviors, that the coping skills are really important in mental health work. And again, with that parent collaboration, I always teach them to both the child and the parent, because that way we can reinforce at home what we're learning. And again, that collaboration word comes up. So even mental health professionals in an ideal world with FASD will be collaborating and educating with caregivers and other providers that the child is seeing if that is needed. And then also, the mental health provider can be part of that whole team. So some of the therapy interventions that we're going to talk about are on this list, and I'm going to go into detail a little bit more about each of these things as we go along. My first line treatment that I like to talk to families about is the FMF, or Families Moving Forward program, not to be confused with Formed Families Forward. I know there's a little bit of a tongue twister there, but Families Moving Forward, we'll talk more about that momentarily. It's an intervention for caregivers who are parenting children who have FASD. There's the FASCETS Neurobehavioral model, the cognitive behavioral therapy, which is sort of a standard frontline therapy. We're going to talk about how to adapt that. So if you happen to be a clinician listening to this will be a great time to kind of perk up and notice what are some things you can do to help your kiddos. PCIT, which is parent-child interaction therapy, is another caregiver intervention that we're going to discuss. Dialectical behavioral therapy. This is to promote emotion regulation in parents and kids. I'm going to talk about some trauma-informed therapies and also some sort of off-the-wall therapies, like expressive art therapies and neurofeedback that are kind of experimental, but also that a lot of families find benefit in. So I'm going to go into these in a little more detail. So Families Moving Forward is an evidence-based intervention, which means it's been well studied and had good outcomes for kids who are affected by prenatal alcohol exposure. And this is appropriate for kids that are about 3 to 13 in that age group. And so by participating in this program, families receive comprehensive support that is specifically tailored to the challenges that their child is having. And how that works is it's a bi-weekly therapy that it's about 90-minute sessions. So it's kind of nice. A lot of families like this because it's not a weekly commitment. The sessions are a little longer, but they are focused on the caregiver. And some of the sessions do include the kids. So that's why it's considered a family intervention. There's observations, there's behavior planning using the positive behavior support that I was referencing in the previous slides. And a lot of education as well. So it's very comprehensive, and it also has some opportunity for caregivers to collaborate with the therapist and their child's providers and their school. So it's very supportive of the multidisciplinary approach, which can be great, for families that are looking for that. It also integrates therapy techniques that help parents modify their own responses to their child's behavior. So it's not just behavior planning for your child, it's also behavior planning for you as a parent. So this is what we want to enhance so that we can improve relationship with our kids, right? And so this really helps with reduction in disruptive behaviors by focusing on specific behavioral interventions, but using accommodations and strategies that are effective for kids that have neurobehavioral disorder. So it's not just run-of-the-mill behavior planning. It's very specialized. And then parents are going to get a lot of education and skill building. So the idea there is so that by the time you finish the program, which usually takes about, on average, 8 or 9 months to finish, depending on how many sessions you make or miss. But the idea here is to give parents the confidence to do this on their own. And the FMF now has an app as well called FMF Connect, and that extends the program's reach by giving a platform for families to seek support in between sessions, which is really cool. So that's kind of a little pocket guide to FMF, which is helpful. So we also, in addition to FMF, the second line of defense in FASD treatment is the FASCETS Neurobehavioral model. FASCET stands for Fetal Alcohol Spectrum Consultation, Education, and Training Services. So it's a mouthful there, which is why we call it FASCETS. But this model really emphasizes the connection between what's happening in the brain and the behavior that we're seeing. And it's appropriate for all ages. So we can use FASCETS treatment on toddlers, elementary school kids, teenagers, adults, and elderly folks. I mean, everybody can benefit from FASCETS if they have any neurobehavioral conditions. So this is not only FASD specific, although that was what its original design was for. But I've been able to use this learning model to really do a lot of work with families, even if there is no alcohol exposure. So it's designed to help caregivers understand and address behaviors and do some behavior planning as well. There's a heavy educational component here and a brain science component so that caregivers can really understand. And this is very adaptable too. So in my practice, I actually do a lot of neurobehavioral work with the kids as well. So where FMF is more parent focused or caregiver focused, FASCETS is something that I can help kids understand their brains too and learn how to make their own accommodations. So that can be helpful to do alongside the parent work. So some of the elements of FASCETS that make it unique and very effective are the brain behavior connection, the individualized approach. So like FMF, this encourages really personalized strategy. So every family that goes through FASCETS is getting a different treatment. that's tailored for their child's needs. This can also be used with multiple kids in a family. So that's kind of where FMF kind of has like a targeted client that it's focused on. I like facets when I have a family that maybe has 2 or 3 kiddos that all have neurobehavioral stuff going on, and we can kind of, adapt as needed. It's also trauma-informed approach. So behaviors are approached through a lens that considers past trauma that kids may have had. And so that's also really, really helpful. And then it focuses, much like FMF, on empowering caregivers as well. And so they can learn to create change and feel, like good advocates for their kiddos. So I also want to talk a little bit about cognitive behavioral therapy. If you've been in therapy, you've probably heard this word before, this phrase before, or it's kind of a buzzword. CBT is also the abbreviation. And most mental health professionals are trained in CBT. It has kind of a traditional feel to it. It's the primary care of mental health, if you will. It's a very structured approach, which works well for kids with FASD. But the idea is to modify maybe thought patterns that aren't helpful and behaviors that aren't helpful. So a lot of it is identifying feelings, learning about those thought patterns, changing unhelpful thought patterns, and then creating coping strategies for behaviors. But what we have to do with kids who have FASDs is we have to modify this and how we approach this a little bit. Because it can really be beneficial in addressing things like impulsive behavior, aggression, even social skills we can work on in CBT. And there's no real age range for CBT, but I would say around the age of 3, is generally a good time to start teaching some of those base level coping skills and doing feelings work and things of that nature. Some of the benefits of CBT are reduction of impulsivity and aggression, as I mentioned. Recognizing triggers, that can be really difficult for kids that have brain-based challenges, is really understanding why they're feeling the way they're feeling or what happened to set them off. And so this CBT really focuses a lot on that. And so it helps to effectively reduce some of that behavior, that impulsive behavior. Social skills, this can help with enhancing understanding. I do a lot of social stories work with kids and social role playing and things like that, problem solving skills, which just leads to better peer interactions for these kiddos that might be struggling with friendships and things. Also, enhancement of executive functioning. So CBT can really improve executive function skills. So we can work on things like inhibitory control, also known as impulse control, regulating big feelings and emotions, and things like that. So there are some benefits. However, we are going to talk in a few slides about how to modify some of these therapies to be more beneficial. The PCIT is parent-child interaction therapy. This is appropriate for kids that are from about age 2 until 7. So this is definitely more of an early childhood intervention. This is an up-and-coming approach. It is an evidence-based approach, but it's up-and-coming for FASD specifically. More studies are definitely warranted. But a lot of families have found improvement in communication and fostering positive behavior because this helps parents. It's kind of a parent coaching program that helps parents learn to manage the big behavior more effectively and to communicate better. And so while we do need more research on it, it is showing some promising results. So some ways that PCIT can benefit the parent-child relationship are just, strengthening emotional attachment to, between parent and child, improving behavioral outcomes. So, if we teach parents how to manage behaviors through how to communicate in a better way with their kids, we're going to have better outcomes in the relationship as a whole. And this helps parents gain confidence, and skill build. So if you're a parent who really, struggles, like what am I going to say? What do I say to my kiddo when they're having a meltdown or they're being irrational or whatever it might be? Like it gives us the language and the tools to be able to do that. And therefore reducing parental stress. So, this can really be a helpful relational therapy. while it's not FASD specific, there's definitely always an element of parenting stress that's pretty high in the families that I see. And then we have DBT. So this is a cognitive behavioral therapy that's been adapted. It was created originally to treat borderline personality disorder. However, dialectical behavioral therapy has now become a frontline treatment for a lot of conditions that require that cause people to struggle with emotion regulation. So because that is really prevalent in this population, it's a treatment that can be really effective. Like PCIT, it needs a little bit more research to establish scientific efficacy, but the studies that are available are promising. So I use quite a bit of DBT in my practice. It's really more appropriate for older kids and adults, although there is a child DBT program called DBTC that can be really helpful. There's a caregiver component to that as well. But traditional DBT works well for kids ages 13 and up. So I use this a lot with my young adults and adolescent clients. I also use it a lot for parents because if you have a kiddo that is struggling with behavior, you know how dysregulating that can be, even as a parent. So DBT strategies can just be helpful across the board to integrate into therapy. Some of the benefits that DBT can offer are emotion regulation. So it really provides, it's a very structured program, and there's homework and there's a lot of, there's some flexibility there, but it still provides a structure that can be helpful for these kiddos to moderate intense emotional responses. So this is really, I mean, we can use this therapy with kiddos who are self-harming or who are suicidal or, who've been placed inpatient, like this can be really helpful for that level of distress. And the American Academy of Pediatrics highlights the importance of like behavioral specific interventions for kids with FASD. And so DBT kind of falls under that category. But like I said, it just really needs more studies to show its efficacy with this population. So those are I could go on and on for hours, right, about different modalities of therapy, but these are the frontline, most neuro-friendly therapies that are available today. And I want to talk about some adaptations to these therapies that can be made. So some of these, if you are a parent or caregiver and you're looking for therapy for your child, these are things that you can look for in a therapist. These are qualities. So this slide I definitely would save. You could take it with you and take it to a therapy appointment and say, hey, how do you work with kids? What's the structure of your sessions? You can use this as a tool. If you're a provider or clinician, these are some ideas, things that you can do. And again, this is not an exhaustive list, but these are some of the most helpful things that I found in my practice to create an adaptation to traditional therapy. So communication, we want to use simplified language. So when we're teaching a child a new skill, or we're talking to them about something that's happened in their day, or anything where we're doing a verbal exchange, we want to keep it simple. I always ask one question at a time. My responses are simple. I always just try to be really mindful of this so that we're not sort of babbling, to these kiddos. They really need time to process what's being taught. So processing time is another communication consideration. Giving concrete examples as well. So, if we're learning a new skill, and you can do this at home as well, you're learning a new skill, let's say you're learning a new coping skill, and you want to give examples of what that looks like and not just talk about it. Role playing it can also be really helpful, just because these kiddos need to see it in action. A lot of them are kinesthetic or hands-on learners. So doing a role play of a new skill that you want them to learn can really show them, hey, this is how we do this and this is what it looks like. So they'll be more likely to remember it, or at least remember how to do it if prompted. And lots of repetition and review. So a lot of times in therapy, the therapist will teach a strategy in one session and then move on to something else in the next session. But in neurobehavioral therapy, we want to repeat and review a lot. So even though I might be bringing in a new concept in the next session, I'm going to go back and review often and kind of check in on those skills to make sure that we still remember what we talked about. Session structure is also something to consider. Most traditional therapy sessions are an hour or at least 45 minutes. And a lot of these kids cannot stay in a session that long. Even if you're in a, you're doing like play-based therapy and you have toys available, they may be able to hang out and play for an hour, but the actual therapeutic session is not going to be that long. So definitely shorter sessions are essential. I often will just do 20 or 30 minutes if that's all that they're able to do, especially if it's a virtual session. But a longer duration of therapy. So what that means is maybe instead of being in therapy for 6 to 12 months, we might be in therapy for 18 to 24 months, so shorter sessions, but longer duration. And also having a session routine that's predictable. So when the kiddo comes into the therapy space, whether it's virtual or in person, the routine is essential. So we're going to do this, we're going to check in, then we're going to do this, then we're going to do this, then we're going to end. Maybe having like a ritual for opening the session, a ritual for closing the session, so that that becomes familiar and feels safe. And also we want 100% to have the caregiver and family involved. Executive function. So this is going to be some of the, ADHD type stuff, for kids who struggle with time management, organization, emotion regulation, attention problems. We want to make sure we break down tasks into little pieces. So I'm not going to give them 4-step directions. I'm going to break that down into 1 step at a time. I'm going to use visual aids because those are helpful, just as I have this up on the screen right now with all these colors, right? So you can get, I can my brain can sort out, okay, that orange box is this and the yellow box is this. Visual aids can be really helpful to help the brain remember and retain. Definitely incorporating movement. Even in virtual sessions, I always have a movement activity, whether it's a game or just, if I'm trying to do something more structured and the kiddo I'm working with is getting really antsy, we'll get up and do a quick jumping jack brain break or something like that. And then emotion regulation skills. So really, this is something I would say I work on more than anything else if I'm working directly with a child. Sensory considerations, we'll always want to have those as well. We want to keep lighting low, keeping toys in the space to a minimum, minimizing other distractions. That's especially true for virtual therapy. If a lot of kids will be like sitting in the middle of the living room with the family around, I definitely try to minimize that if possible. And then giving them sensory tools and fidgets they can, play around with while they're in session is really helpful. Parent and caregiver involvement, again, this is essential. So caregiver education, promoting attachment, positive behavior strategies, and emotional support for parents. So this is really, really key. It's not, there's not a lack of benefit to working with a child one-on-one, but you're not going to get the outcomes that you will if the parent is involved. So if you're a parent or caregiver, you definitely want to be involved. If the therapist is kind of, feeling uncomfortable with that, it may not be the best fit. And then focusing on strengths. So this is where that strength-based perspective comes into play. And one of my first questions I always ask families is, what are your child's strengths? Because I'm going to be really using those a lot to build them up. These kids have had a lot of being torn down. So building them up is really important. So I always want to communicate any little success that we're having in the session. And even over the long term, kind of letting you know, hey, when you first came, this is what was happening. And now look, and really just often checking in on their progress. Introducing challenges slowly. So if something's going to be really hard for them, we want to pace ourselves with that and not throw them into it too quickly, specifically if there's a significant trauma history. Setting goals that are realistic, that they can achieve and feel good about. And also self-advocacy. I, just as a therapist, really try to help kids learn how to self-advocate as young as possible. Obviously, our expectations have to be low at first because they're not going to always be able to do that. But as they get older, the more practice they've had, the more effective they're going to be with that. So these are just some adaptations that a therapist might consider making. Definitely, again, not all of them. I could have a laundry list of more, but these are some really, really common and effective things that we do in neurobehavioral therapy. And I also want to just quickly address the trauma piece. A lot of you are raising kids who have come from hard places. And so treating trauma is really essential, but how do we do that in kids that are prenatally exposed to alcohol? There's specialized considerations because we have this intersection of trauma and prenatal alcohol exposure. So we're trying to help a child heal who has a brain that hasn't formed in a typical way, and that's challenging. So one of my favorite trauma interventions is TBRI, which I'm sure a majority of you are familiar with, but if you're not, we'll just quickly talk about that. It is an intervention called trust-based relational intervention that focuses on attachment and is trauma-informed. And it's designed to meet the needs of kids who have experienced any kind of relational trauma. So it could be abuse, neglect, kids that have been in foster care or institutionalized really benefit the most from this treatment. It is not specific to FASD. However, it can be a helpful approach to kids who have FASD because of the intersection with trauma history. So the principles of TBRI are based on building relationships and helping children feel safe. And they're based on 3 principles, which are connecting, and that's the attachment part, learning to connect and build relationships with kiddos. Empowering, which is creating healthy and safe environment. And then building like a felt safety for kids. And then correcting, which is the behavioral piece where we guide children in a gentle way towards reinforcing appropriate behavior. And this is from infancy to young adult. I mean, this intervention can be used all the way through childhood. So it's very, very helpful. And I do a lot of TBRI work in sessions as well when it's needed. And just real quick to kind of wrap things up, I'm just going to go over some alternative approaches to treatments. These may not necessarily be evidence-based. Some of them are up and coming, but just to kind of, if you're into that, some people really like to do some alternative or unique things to help their kids heal and work through stuff. So expressive art therapy is great. I use a lot of this in my work only because a lot of kids that I work with can't verbalize. And so expressive artwork can be really, really make movement for them. Mindfulness and meditation, yoga, all of that is really great. Teaching kids, how to regulate their bodies and their brains. Nutritional interventions, so talking about diet and supplements, definitely with the help of specialists, but this can be really make big movement on behavior as well. A lot of families have looked into animal-assisted therapy, so like equine therapy with horses, or there's some programs that provide service dogs to kids with FASD, so that type of stuff can be really, really healing for them as well. In fact, at the Florida Center, we had a service dog that was part of our treatment team for quite a while when I used to work there, so that was really cool. Neurofeedback therapy is also an up-and-coming area. Some of you might be familiar with this, but it's kind of, I liken it to like neurofeedback sessions are kind of like defragmenting your hard drive, which the hard drive being your brain, kind of aligns areas of the brain for better functioning. And then outdoor and nature-based therapies too, especially if you have a kiddo that just hasn't been successful with anything else, outdoor and nature-based work can be really helpful too. So you can incorporate a lot of these things together with mental health work as well. So just to wrap things up, I have a list here of some of my favorite online resources. Nate Sheets, Jeff Noble, both of them are really great. Jeff Noble's work, he's very specific to FASD. Nate Sheets, he does he does a lot of cognitive support work with kids with neurobehavioral stuff going on, including FASD. I put a link on here for the Families Moving Forward program and the facets as well, and also the Karen Purvis Institute, she was the creator of TBRI. So just as some resources for you guys. And then I put a link at the bottom to FASD United as well, because that's a great hub of resource and information. Again, not an exhaustive list. These are just a few of the ones that I have found the most helpful. And last but not least, we have a book list that I put here since the slides are going to be shared. So you'll have these websites and book lists available to you. Some of these are for kids and some of them are for caregivers, but these are some books that I personally have read and found really helpful for my families. Fantastic Antone Grows Up. That one's a great one for teens and adults. And then There's a bunch of them that for caregivers, and then at the end, Finn has FASD. I think this is a newer book, but it's super cute book for younger kids. So if you guys like to read, there's some material for you there. All right, so that concludes my presentation. If there are any questions, I can go ahead and take those.
Yes, thanks so much, Jessica. Wow, that was fabulous. So succinct and really, really practical. So, uh, huge benefit for many here, I'm sure. We did have a couple questions, so let me just start going through those. Question specific to families moving forward. Can you talk about whether that can be done remotely or virtually versus being in person? And also, is FASD diagnosis a prerequisite for families moving forward?
Oh, that's a great question, or great questions. Yeah. Yes, families moving forward can be done in person, and it can also be done virtually. I actually really enjoy doing it virtually because there is some observations involved, and I found those to be really, really useful virtually with kids. Only because being like going to someone's home to do an observation can be kind of, can alter the child's behavior, but being virtual allows me to really see what's going on, without that intrusiveness. So, but yes, in general, I think they're both equally effective. I've done it both ways, and families have gotten a lot out of it. So, as far as the second question goes, yes, the child does have to have a prenatal alcohol diagnosis of some sort. So it doesn't have to be full-blown fetal alcohol syndrome. If they have a diagnosis along that spectrum anywhere, then the FMF program would be appropriate.
Wonderful, thank you. Getting some positive accolades for the wonderful presentation that you did. I'm looking for other questions. Stacia, did you have any questions that you would like Jessica to address while I look for others that are coming in?
Yeah, I don't see any in, I think they must all be going to you, Kelly, because I'm not catching any of those. But I actually do have a question myself. So I'm
Okay.
going to put that out there. For neurofeedback, is there an age that they find that is more effective for it? Do you
That's
know
a great
anything?
question, and I actually don't know the direct answer to that. I
Okay.
will say, my relationship with it, at least in my area, with the facilities that have been providing it, I've seen kids going at 4 or 5 years old all the way up to adulthood. So I think it's pretty broad.
Okay. Great.
Another question about DBT. So we get a lot of requests from folks about DBT. And sometimes people talk about DBT, official DBT, and then some people talk about DBT light or variations of DBT. And we actually just had, I'll put this in the chat, we just had, for those in the Northern Virginia area, George Mason University just shared an announcement that they have a new DBT 8-week course, group course. So can you talk a little bit about sort of what DBT looks like or is supposed to look like and how that might vary for kiddos with prenatal exposure?
Yes, also a great question. So traditionally, DBT can be done individually with a therapist one-on-one. It can also be done in a group. The way that it's being done in a lot of places now, and there's no right or wrong way to do it in this capacity, but there's usually a group that meets like once a week, and then the individual also gets one-on-one therapy alongside that with the DBT trained therapist. So that I think can be really beneficial, as long as the therapist has some knowledge that they're going to have to adapt things a little bit. So if you have a teenager that's going to groups, they're going to be in a group with neurotypical kids. And so that's something to consider. But that can really be good for social functioning depending on where they're at. So again, that would be, I think, a very individual decision based on, what their capacity is to participate in a group like that. But if you have a facilitator who's really open and willing to learn, it could be a great fit.